My name is Magni Hamso. I'm an internal medicine and addiction medicine physician, and I'm the medical director for the Division of Medicaid at the Idaho Department of Health and Welfare. I'm also a staff physician at the Boise VA, and I'm on faculty with the University of Washington. Today we're talking about starting buprenorphine. I'm glad that you're here to learn about treatment of opioid use disorder. According to data from the Centers for Disease Control and Prevention, in 2022, over 109,000 Americans died from an overdose. Approximately 75% of those deaths involved opioids, with the reported and predicted number of deaths involving synthetic opioids such as fentanyl also increasing. The opioid epidemic was declared as a national emergency in 2017, and since then we've just continued to see deaths rise. We've seen this here in Idaho as well. In 2022, we had 381 individuals die from an overdose, with most of those from opioids and approximately half of the deaths involving fentanyl. Learning about how to prescribe buprenorphine for opioid use disorder, you can help participate in the fight to turn this epidemic around and save lives. So today, we're going to accomplish a lot, but it is really intended to be a point of care that you can consult when you have that patient in the office or you have that patient on your schedule that day and you just need a refresher for how to do this. So we're going to define and diagnose opioid use disorder. We're going to identify who is likely to benefit from office-based opioid use disorder treatment. We're going to demonstrate how to start someone on buprenorphine and naloxone, and there are really two approaches, so traditional induction and microdosing. And then finally, we're going to apply the principles of harm reduction to office-based opioid use disorder care and really recognize how important primary care is in fighting the opioid epidemic. So I think it's a lot easier to think about a new treatment or medication in the context of a patient case. This patient is not one of my patients. It is a fictional scenario, but very similar to patients that I have taken care of. This is a 25-year-old who's interested in buprenorphine after a friend nearly died from an opioid overdose event. Their use has recently escalated, they're spending more and more money on drugs, and they are injecting multiple times, so they've escalated to injection drug use. They're using heroin. They've been to the ER multiple times with skin infections. They've been in situations where they've had to share syringes, though mostly they do obtain them from the syringe services program in town. Occasionally, they mix the heroin with alcohol and benzodiazepine, but that's not regular. They do use marijuana and do smoke tobacco. They have had a period of sobriety that lasted for almost 2 years. They were incarcerated at this time. In terms of other treatments that they've done, they've been in AA, didn't really like it, have done counseling before when incarcerated, but not particularly interested in that right now. They have tried buprenorphine from the street before and did like how that helped them feel much more functional and without persistent withdrawals from opioids. They got started on using opioids after an appendectomy when they were 21, and their last opioid use was earlier this morning, and they're actually already starting to have, a couple of hours later, have some cravings and withdrawal. In terms of past medical history, they do have a history of depression, but have never been hospitalized related to that. They've never had a suicide attempt. They have had treatment for depression in the past, specifically an SSRI and counseling, but again, they're not currently in care. And in terms of pertinent additional social history, no children, some college, used to work as a shop manager, but recently is unemployed. They live with their partner, but the relationship is currently rocky. Their partner is also using and not ready to quit. In terms of family history, they have a parent with alcohol use disorder. In terms of exam, they're sitting here in front of you, they're well appearing, neatly dressed, they do make good eye contact, but are a little bit fidgety, and you do see signs of track marks on their skin. In terms of labs, the urine drug screen that you got in the office today shows marijuana, it shows opiates, but that's it. You got a rapid HIV and a rapid Hep C, which were both negative. You checked the prescription drug monitoring program and did not see signs of any other controlled substances. So in terms of diagnosis, this person does meet criteria for opioid use disorder, and that's according to the DSM-5. And you don't necessarily need to go through a checklist. You get this as part of your typical history, but it is helpful to go through it one by one together to show how they do meet actually severe opioid use disorder. And the DSM-5 has 11 different items that help you make the diagnosis. You only need two to meet criteria for opioid use disorder. And if you have over 6, then your diagnosis is severe opioid use disorder. And these symptoms need to have been present for about a year. And if you have been prescribed opioids and are taking them appropriately under medical supervision, then the pharmacological criteria, so tolerance or withdrawal, would not be sufficient to meet the diagnosis. First, we can talk about impaired control. So there are 4 criteria that sort of fit that category. Using larger amounts over a longer period of time, inability to cut back, spending more time getting, using, recovering from using drugs, and having cravings. Our patient absolutely meets all 4 of these. So already we're into at least moderate opioid use disorder. In terms of social impairment, we're thinking about failure to fulfill major obligations. We're thinking about social or interpersonal problems related to use. We're thinking about important social activities that are given up due to use. Our patient recently lost their job, right? They're having relationship problems. We don't know about important social activities given up to date, but at least meets 2 out of those 3. In terms of risky use, physically hazardous use, we don't really know, but I think we could say sharing needles meets risky, physically hazardous use. And continued use despite associated recurrent physical or psychological problems. We don't really know the status of her depression, but we do know that they've been to the ER multiple times with infections. And then the pharmacological tolerance and withdrawal, they meet both of those. So really 10 out of 11, potentially 11 out of 11. So this person has severe opioid use disorder. So this person meets criteria for opioid use disorder. They have a severe opioid use disorder and they need medication. Medication for opioid use disorder is life-saving, and it's really the standard of care and first-line treatment for this condition. Is this person a candidate for office-based buprenorphine therapy? Yes. Should we start them today? Yes. Are they too complex for primary care? No. There are definitely parts of their story that make you concerned that they might struggle more than someone else. For example, buprenorphine combined with benzodiazepines and alcohol is a little bit more dangerous if there wasn't benzodiazepines and alcohol in the picture, but buprenorphine plus benzo and alcohol is always going to be safer than heroin or fentanyl plus benzo and alcohol. And of course, polysubstance use is pretty much the norm at this point. It's rare that you find someone who has only a primary opioid use disorder. And so this is not too complex for primary care. Are you going to need to work closely with them, support them, perhaps connect them to care for their benzodiazepine use and alcohol? Yes, but you can take care of them in the office. So you've made the diagnosis of opioid use disorder, and now it's time to talk about next steps in treatment. And the number one thing at this point is just emphasizing how happy you are that this person is here in the office with you. It takes a lot to get there and to acknowledge that they have a problem, they need treatment. It takes a lot sometimes to come to the healthcare setting and ask for help because sometimes prior experiences have not been positive. So really just emphasizing, making it clear that you are so happy that this patient is here is super important because buprenorphine is a life-saving medicine. It is the primary treatment for opioid use disorder. Buprenorphine is a partial opioid agonist, and it is extremely safe and effective. A partial opioid agonist means that it stimulates opioid receptors, but only so far. It has a ceiling effect, so when you get to a certain dose of buprenorphine, going up on the dose further is not going to do anything at all. And that is helpful because taking too much is not going to give them positive reinforcement, and taking too much is not going to lead to respiratory depression. So buprenorphine has a safe ceiling effect. Another reason why buprenorphine works so well for the treatment of opioid use disorder is it binds incredibly tightly to those opioid receptors. It has a strong affinity for those opioid receptors. And that means that once you have bup on board, it is very difficult for other opioids to get in. A little bit can get in because it's not perfect and every receptor is never, fully occupied. However, most of them are, and very little of that full agonist opioid, that heroin, that oxycodone is going to get in. So that means someone's protected from an overdose when they're on buprenorphine. As well, buprenorphine has a slow onset of action. When they take that medication, they're not going to get a rush. And once they are on a stable dose, they're really not going to get any sensation at all, right? And so that is also helpful. Finally, it has a really long half-life, meaning it can be dosed once a day. Sometimes we dose it twice a day. There are scenarios where we do it most often, but really those withdrawal symptoms go away. Someone's not brought up and down having to dose something multiple times a day. They can sort of feel quote unquote normal with once a day or twice a day dosing. Buprenorphine is combined with naloxone in buprenorphine naloxone. The naloxone piece does not do anything in terms of treatment of the opioid use disorder, but is there for safety reasons. So at the beginning of treatment, sometimes people do the wrong thing and they inject that buprenorphine, right? And so the naloxone helps prevent them from getting much of a high. It's quite attenuated when the naloxone is there, and it protects them from an overdose. So that naloxone piece also makes this a very safe treatment. And one important thing to note that we actually often have to message to patients and remind our colleagues about is that it is not replacing one drug with another. Someone who is taking buprenorphine for opioid use disorder, they're in treatment, they're in recovery, they're abstinent, they are sober when they're taking that buprenorphine. It is not replacing one drug with another. And the treatment is typically long-term, oftentimes years, right? It really depends on that individual risk-benefit calculation. And staying on buprenorphine is always going to be safer than returning to heroin use. And you know, a couple years in, maybe someone is ready to come off, like they probably are organized enough that they could tolerate a very slow taper, but if they don't feel ready, if they are so afraid of what they could lose if they return to use, then we just keep them on buprenorphine. So at this point, let's talk logistics. So when you have that person with you, you made the diagnosis, you've talked to them about how buprenorphine works and gotten their buy-in to get started, we need to take care of the nuts and bolts. So one is identifying some treatment goals. It might not be fully abstinent from opioids. Obviously, that's what we would ideally prefer, but not everybody's going to be ready for that. Hopefully they'll have a reduction in their use, but hopefully we can also identify some other goals. Like maybe it is finishing their college degree, or maybe it's getting back to work. Maybe there's an opportunity to get that work as a manager at that store back, right? So there might be goals like that your patient will set that you can help sort of track how they're doing in terms of their treatment. Because you're not always going to see opioid-free urines, especially at the beginning. We need to make sure that we do a treatment agreement. This is very similar to a pain agreement or any sort of informed consent really prior to pursuing a new treatment. It highlights basic expectations. You know, they need to come to most of their appointments. Every now and then they're gonna need a drug test. It identifies the risks and the benefits of the treatment. It outlines the alternatives. Again, today we're talking exclusively about buprenorphine, but there are other options for treatment of opioid use disorder. Not all of them life-saving and not all of them available in primary care, but there are other options like methadone, extended-release naltrexone, psychosocial supports. We also need to make sure to check that prescription drug monitoring program. We already did this for this patient and it didn't show anything. You know, at the beginning of treatment, if somebody has been, you know, getting opioids in many different places, they've been sort of quote unquote doctor shopping, that's part of the disease and is not surprising, right? It's more about what happens next. And that's why we need to always check it when we see these patients. And it's also about knowing about that medication for ADHD or that benzodiazepine for anxiety that they might be on so that you can coordinate care with their treatment provider. Doesn't mean that you're not going to prescribe buprenorphine, but it's just important that you're all on the same page regarding what other controlled substances they're on. In terms of urine drug testing, you know, it's nice to have point of care drug tests in the office that are available within minutes, because then you and the patient can be on the same page right away about what that urine shows. But again, it's not necessary. It's okay for it to be sent to the lab. Like, it is rare that urine is really going to impact whether or not you prescribe buprenorphine that day, both that first day and at follow-up visits. On that first day, in addition to getting what we call a qualitative drug test, it gives you a sense of what's in the urine, whether benzodiazepines, methamphetamines, certain types of opioids. It's also helpful to get a confirmatory or quantitative test to look for things like fentanyl and certain types of benzodiazepines that are just not picked up by the qualitative test. It doesn't have to happen every time, but occasionally it is important because you might miss things. I shared some labs for this patient. They had been tested for Hep B and hepatitis C. They'd been tested for HIV. We often also test liver tests. Again, not required to start someone, and actually getting a blood draw can be potentially triggering for someone who engages in injection drug use, and you should not delay treatment to get those labs. We used to think that buprenorphine caused hepatotoxicity, but we don't think there is much risk to the liver from buprenorphine, so it's okay to delay those labs. But at some point, all of these are helpful to check. And then a final piece of the logistics before getting to actually starting someone on buprenorphine and prescribing that medication, it's making sure they have naloxone. A lot of patients have administered it. They've seen people be revived by it. It should be a pretty quick discussion regarding how it works, but it is super important that they have access to naloxone. Hopefully they won't need it, right? They're entering into treatment, but they could be a first responder for somebody else. So in this slide, I'm just showing you some different formulations of buprenorphine. There are a couple of different brand names. It comes in some different doses. Which you prescribe really depends on the insurance that your patient has and sort of their preference. Some people like the tablets, some people prefer these little films, but it's really up to that patient and their insurance coverage. I mostly prescribe the 8 milligram tablets or the 8 milligram films, and again, it's combination buprenorphine naloxone, and it's just for ease of use, right? Most people probably end up on a dose of around 12 to 16 milligrams of buprenorphine a day. They're pretty easy to cut in half. Working with just one dose makes it easier to titrate the medication, so in general, that's what I tend to recommend. It's also what pharmacies tend to have in stock, and of course it's very important that when you send this prescription for this life-saving medicine that your patient actually can pick it up. And so the 8 milligram dose is probably one of the most commonly prescribed ones, and so it's easy to use that one for that reason as well. I mentioned the mono product. Again, not often that I end up prescribing this. Occasionally somebody has severe headaches as a result of the buprenorphine naloxone combination. It is not common, but there are situations like that when you'll go to the mono product. Also in pregnancy, but again, the combination product has been shown to be safe in that situation as well. So when we're getting someone started on buprenorphine, the reason why we can't just write the prescription and sort of send them on their way is that we need to prevent something called precipitated withdrawal, and we need to identify a therapeutic dose. So we talked a little bit about the pharmacology of buprenorphine, and I mentioned this strong affinity for the opioid receptor. Buprenorphine binds really tightly to the opioid receptor. That means that if there are opioids still in your system when you take your first dose, you're going to push off that opioid and they're going to experience a sudden and intense withdrawal. It is not dangerous, but it's not helpful when you want them to buy into taking this medication. And so that's part of why we're doing this induction, to avoid them experiencing precipitated withdrawal. And then again, that therapeutic dose. Because buprenorphine is a partial agonist, even if somebody was getting prescribed opioids, you cannot convert the morphine equivalents in the same way that you could between two full agonist opioids. So you just don't know what those are going to need. So that's why we have to do this induction. So when you're starting someone on buprenorphine, there are two different ways of doing this. There's a traditional induction where you basically have someone go into withdrawal. They have to be in mild to moderate withdrawal, and we'll talk about what that means before they can take their first dose of buprenorphine. The other way is microdosing, where you start with really tiny doses of buprenorphine, push it up over time, and over the course of a few days to a week, basically replace the full opioid agonist with the buprenorphine, and we can avoid withdrawal that way. So when we're talking about traditional induction, where you have someone go into withdrawal before they take their first dose, you could do that actually at home or in the office. When buprenorphine was initially approved for prescribing here in the United States, we were largely doing in-office inductions. That's where you have somebody actually come into your clinic in withdrawal. You assess them to see if they're in enough withdrawal. Then you give them their first dose of buprenorphine, see how they respond, and increase the dose while they're there with you. In general, we don't do that anymore. In-office inductions, I would argue, are provider-centered, right? Like, someone has to plan their withdrawal for when they have an appointment in your clinic. It's an uncomfortable environment. It really disempowers the patient and keeps the locus of control with the provider, and we really want to reverse that, right? We want to empower patients to be in charge of the recovery. as well, like these patients are so familiar with withdrawal symptoms. That is what they're trying to avoid every day with using, right? When you're in the midst of an addiction, it's not about getting high anymore. It's about feeling sort of normal, right? And not having those withdrawal symptoms. And so they know what withdrawal feels like, and they can identify this on their own without the provider that probably has a lot less experience with this, sort of using a checklist to do that in the office. And it's actually been looked at through some small observational studies, but then also lots of clinical experience. And in general, that is what we do these days. We do at-home inductions, and I've actually never done an in-office induction. I have started hundreds of people on buprenorphine at this point. So when we're doing the traditional induction, we have two goals. One is avoiding precipitated withdrawal, and the other is identifying that therapeutic dose. So we're going to start with talking about avoiding precipitated withdrawal. So someone needs to be in withdrawal, right, before they can start. And how we do that is in two ways. We need to know how much time since their last opioid use, and we need to know what symptoms they're having. Time depends on the drug that they've been using. Heroin's pretty short acting. 12 hours should probably be sufficient for them to have enough withdrawal symptoms to get started. Extended release morphine or oxycodone, you probably need 24 hours. Methadone could even be up to 72 hours, right? That half-life can be really long in some patients. And then you need withdrawal symptoms. I tend to just say, give them a list of withdrawal symptoms and tell them that they need at least 5 in addition to that time, and then that works for most patients. There's also scales out there similar to the clinical opiate withdrawal scale. It's actually called the subjective opiate withdrawal scale. That is a pretty big document with a checklist that patients can use. But again, even just giving them a list of symptoms can be sufficient. And the part of the reason why you need symptoms and time is that different people experience withdrawal symptoms differently. Some people are going to be very bothered by a mild muscle ache, and someone is not going to be, right? So symptoms are so subjective that you really can't use them alone. And we want people to be successful. This is really scary for patients, right? Like they are trying to avoid withdrawal symptoms when they're treating their addiction with heroin, right? That is what they're trying to avoid. So we need to make sure they're set up for success. So that means prescribing medications that they can take to help mask some of those symptoms. So clonidine for anxiety, 0.1 mg 3 times a day. 10 tabs is typically enough to get them through a couple of days. Loperamide if diarrhea is something that they struggle with during withdrawal. Trazodone is sleep is their primary issue. We recommend taking ibuprofen or acetaminophen around the clock during the days that they're experiencing withdrawal to sort of mask some of those muscle aches, and then ondansetron if they're having nausea. Not everybody needs all of these medications prescribed, but most people, we need at least some of them, and you really do want them to gather these medications and have them ready when they're going to sort of go through this, because you want to set them up for success. With the traditional induction method, if they cannot get to taking that medication, then right, they're not going to be successful. Fortunately, we don't have to have a very severe withdrawal to get started. Really, the symptoms should be relatively mild. And again, combined with that time piece, you can be, reassured that they are safe to start that buprenorphine. The last piece that we do to avoid precipitated withdrawal is to start them low. And so we start with 2 milligrams, or I typically start with 4 milligrams. Because again, if you start with a low dose, it's not a lot of buprenorphine that's displacing the full agonist opioid. If there is some in their system, it's not going to cause a lot of symptoms. So thinking back to our patient, right? They were using heroin, so we would want to wait at least 12 hours before they could take their first dose. We'd also want them to have at least 5 withdrawal symptoms. So those would be things like muscle aches, a little bit of agitation, maybe some anxiety, maybe they're yawning, they have goosebumps, they have some diarrhea, right? That would be enough to meet the criteria. And then they're ready to start. And you want to start them low so that you don't cause precipitated withdrawal, and also because you don't know what dose they're going to need. Most patients will need a dose of around 12 to 16 milligrams, but you don't know until you try, right? 16 milligrams is probably the dose where you get the most bang for your buck in terms of protection from overdose. So on day 1, right, they're in enough withdrawal, they waited long enough, you're ready to start them. They take the medication under their tongue. I typically start folks on 4 mg, so that's half an 8 milligram tab or film. They put that under their tongue, let it dissolve, we wait a couple of hours. If they're still having withdrawal symptoms, we know that half a tab or 4 milligram was not enough, and they can take that other half a tab or film. That's the maximum dose for day 1, 8 milligrams. They might still have withdrawal symptoms, but that's where they need to take those supportive medications. Day 2, when they wake up, if they wake up feeling well, we know we reached the right dose. And 8 mg a day is the dose for them, and they should just continue taking that every day. If they wake up not able to eat breakfast, they're feeling poorly, well then 8 milligrams is not enough, and we should increase that dose from the get-go. And so that means starting them with 1.5 tabs or 1.5 films, whichever formulation you're using. And again, the tabs are 8 milligrams or the films are 8 milligrams, and so 1.5 would be 12 milligrams. Wait another 2 hours. If they're still having symptoms, you could push that up to 2 full tabs or 2 full films, a total of 16 milligrams. And that would be as much as I would have folks do on their own. At that point, we would want to see them back in the office or see them virtually through your virtual office. Because again, most people are okay on around that dose, and it takes about a week to reach steady state. And so it makes sense to check in with them before pushing it up further on their own. So that's how we do it. This is an example of a patient handout that sort of explains this process. It talks about the medications that were given them for their symptoms, right, of withdrawal. Again, the typical ones are the clonidine, acetaminophen, or ibuprofen, and loperamide. But again, if nausea or sleep are major issues, you should prescribe for those as well. Then you have your list of symptoms, right? These are just your typical opioid withdrawal symptoms. Rather than a scale of severity, it's just yes or no, do they have them? The second page of this patient handout is how to administer it. Buprenorphine is under the tongue, which is a little funky for patients because it's, if they just take that tablet and swallow it, it's not going to do anything. It's broken down by the liver before it has any sort of effect. So it's important that they take it under the tongue and let it dissolve. And here on this page, we also talk about the time piece. So we find out, when do you want to be the last time that you use opioids? Maybe it was the dose that our patient took this morning, or maybe they're not really quite ready and they want to schedule it for over the weekend or whenever is convenient for them. So we'll pick sort of a day and time based on when their last use is. And again, they need to wait around 12 hours since their last use. And then it just goes through the process, right? You start with half a film or tab that's 4 mgs and then push it up over the course of a few days and then follow up. So that's your traditional induction up until your first follow-up visit with them, which again should ideally be a couple of days later. Could be in person, could be virtual, but we need to make sure that we check in. The microdosing approach is a little bit different. So microdosing is an alternative approach to induction, right? Going through that withdrawal, although some patients are ready for it, they just want to stop, don't want to use anymore, and are prepared, right, and can go through that. Sometimes that's not the right way to do it. Sometimes that is really scary for patients, and it makes sense to take a different approach. With microdosing, you start with very low doses, and you slowly over the course of the week push up the buprenorphine dose. During that time, you actually continue the full agonist opioid, whether that's heroin that they're buying, they could continue with their regular schedule, or maybe it's a pain medication, right, that they have had prescribed. They continue to take that. And then when you get to a dose of around 10 to 12 milligrams of buprenorphine, they can just stop it. Because at that point, you've pushed up the buprenorphine dose high enough that it has replaced enough of that full agonist opioid that it should be fine just to stop the full agonist opioid. Again, if somebody has a lot of fear of going through that withdrawal, it's a good option. If someone has chronic pain, and going through withdrawal will not only mean withdrawal, but also severe pain, right? It could be a good option. Or if somebody is on fentanyl or methadone. So fentanyl is interesting because it's incredibly short acting, but it sticks around in your fatty tissues. And so someone has to wait actually quite a long time, probably close to 48 hours, to know that the fentanyl is mostly out of their system to go through the traditional induction. And that can be difficult, right? And so it might make a lot of sense to use microdosing when someone has been using fentanyl. It can work well with methadone too. Like we talked about earlier, methadone has a really long half-life and it differs between people. And so for methadone too, you don't have to worry about that long half-life and the fact that they might have to wait up to 72 hours, right, and have withdrawal symptoms for days before they can take buprenorphine. Instead, you can do microdosing. They continue with their methadone, whether it's prescribed for pain, it's dispensed at an opioid treatment program, or they're using it on the street, they would continue to take it. And then when you have pushed up the buprenorphine dose high enough, they can just stop it. So again, this is a new approach to starting someone on buprenorphine, but really should be an option that's available for anyone. And it actually might be more patient-centered in some ways. So what the schedule might look like is this. Over the course of a week, right, you push up the dose. I'd use the 2 milligram tablets or films in this case so you can get more easily to smaller doses. And you would cut them in quarters. You might say that that's hard with a tablet, but again, the quarters don't have to be perfect. It's just about having smaller doses that you can increase over time. So day 1, you start with a quarter. That's a 0.5 milligram dose. If they tolerate that well, day 2, you do a quarter twice a day. Day 3, half twice a day. And over the course of a week, you push it up. And when you get to a dose of 16 milligrams or a day before when they're on a dose of maybe 12 milligrams, you can actually just stop that full agonist opioid. Because again, there's enough buprenorphine in their system that is occupying those receptors. So the patient should not have withdrawal symptoms. They should not have pain when they stop that full agonist opioid. So now that we've gone through the induction, right, that's the first few days. You've chosen your approach. After that, it's important to follow up with the patient. Most patients should be seen a few days after you get them started so that you can help troubleshoot if they're running into issues. It doesn't necessarily have to be in person. It could be on the phone. It could be through video. But again, you want to check in with them to make sure that they're not struggling and that there's not anything that they need for you. Typically, I'll see somebody once a week for a couple weeks, then every 2 weeks, then once a month. So you really do follow them closely in the beginning. In the beginning, you also will do drug testing most of those visits. You want to see how they're doing, right? Sometimes people don't feel empowered to share that they are actually still struggling and still using. So sometimes that drug test can be helpful for that. It's definitely not about finding them out, right? It's about making sure that you're both on the same page about what's going on. Something that is very key is to prescribe beyond their follow-up date. Give them a couple of days extra all the time. Not because you want them to take extra, but because it can be really anxiety-provoking to be close to running out. What if something happens with transportation or childcare? What if your boss doesn't let you out of work, right? And you can't make that appointment and then you run out of this life-saving medicine. So always making sure that you provide a little bit of extra so that they have that cushion and are, protected from an overdose because they have access to their buprenorphine. Given fentanyl has contaminated the heroin supply, we probably need to think of this patient as actually using fentanyl, not heroin. I know that the drug test on admission didn't have fentanyl in it, so maybe we're okay, but we do need to think about that. It's actually possible that microdosing would be the better choice. We could do the traditional induction, but it's possible that we should wait closer to 24 to 48 hours since their last use before taking buprenorphine to avoid precipitated withdrawal. And of course, that can be really hard. Even though we have those supportive medications to help mask some of the withdrawal symptoms, it is difficult to wait that long. So microdosing might be easier. That said, that means that they're coming in for care, want this treatment, want to start using, and you're telling them to continue to use. So they might actually choose to go the traditional route because they're done, right? I'm sharing this just because it's really important to make this decision patient-centered and support them either way that they choose to go. And again, regardless of the approach, it's super important to follow them up closely. But again, keeping in mind that if you, through that follow-up, are creating too many hoops, you could actually preclude success. Buprenorphine is safe, it is a life-saving medication, and ultimately that is the goal, to get the patient to take this medicine that could make them feel better and save their life. And that leads us to harm reduction and really bringing the idea of harm reduction into the care of your patients in the office. And by harm reduction, I mean meeting patients where they're at, providing care that's patient-centered, understanding the continuum of substance use, acknowledging that returns to use are common, acknowledging that abstinence may not actually be feasible, and that doesn't mean that the buprenorphine's not working. Less use is better than more use. Harm reduction means facilitating access to life-saving medication. And that means weighing the benefits of refilling without an appointment against the harms. Not refilling could mean someone going without buprenorphine, being uncomfortable in withdrawal, returning to use, potentially overdosing and dying, right? Like that's a big deal. It means weighing the benefits of requiring things like counseling. Patient can be successful without it, even if they might benefit from counseling. That doesn't mean that we should require it. They might not be ready for it. You can bring it up again in the future. Weighing the benefits of referring to a higher level of care against the harms is also a big decision because somebody might not go. Opioid treatment programs require daily dosing. Someone might not have transportation or the time, right, to be able to get there. And so you really need to know what the situation is like before making that decision. So in general, this means just being flexible, right? And being patient-centered, thinking about what other obligations patients have. Obligations to work, their family, think about what their transportation barriers are. Eliminating those non-evidence-based requirements such as daily med pickups, mandatory counseling, requiring folks to do self-help. If somebody wants to, is motivated, they absolutely should pursue those treatments. If somebody is interested, encourage them to, but again, don't tie the life-saving medication to these types of requirements. It means providing support and seeing people regularly, but at the same time, spacing visits out as patients are able, and consider seeing people virtually and talking to them on the phone. Every contact doesn't have to be in person. That takes more time for transportation. That means they need childcare. There are all of those issues that we do need to consider. And then just be forgiving, right? Like folks with opioid use disorder, especially in the beginning, have incredibly complex lives. And we are asking them to fit into our very structured schedules with appointments at specific times on specific days. And yes, to some degree, that's the reality, right? We have other patients to see, and that's how clinics and hospitals are set up. That said, we can forgive missed appointments every now and then. We can try to accommodate late arrivals as much as we can, knowing that this is a life-saving medication and that it is very difficult for patients sometimes to fit into the requirements of our clinics. The benefits of that continuing that buprenorphine is almost always going to outweigh the harms of stopping that buprenorphine. We know that buprenorphine protects against overdose. We know that folks who stay on buprenorphine have a reduction in their substance use. They have an improved quality of life. They have a lower chance of acquiring HIV and hepatitis C, and they stay in care. So in summary, buprenorphine is a life-saving treatment for opioid use disorder. It is safe and effective, and it can and should be prescribed in primary care. Almost all people with moderate to severe opioid use disorder qualify for office-based buprenorphine treatment. Both traditional home induction and microdosing are viable options, tools that you can use, and really we should approach treatment through a harm reduction lens. Buprenorphine is life-saving. Stopping or not starting buprenorphine can be dangerous, and be as flexible as possible. Too many requirements can cause harm. Again, primary care can and should take this on, and you could save a life, many lives, by doing this work. Thank you for watching this video and learning about prescribing buprenorphine for opioid use disorder. It is a life-saving medication. It can easily be incorporated into primary care, and you really have the power to help us turn around the opioid epidemic.